Hi, so this recording is on women's health, and what we're going to do is we're going to cover the role of estrogen and progesterones, birth control, as well as drugs that affect uterine function. So just as a brief overview, I'm going to cover the ovarian and uterine circles. So this is what happens in the ovaries, and this is what happens in the endometrial lining of the uterus. Now, the endometrial lining of the uterus is the one that sheds, and it's the one that causes menstruation. So if we look at the ovarian cycle, what we can see here is based on a 28-day cycle, it's nicely divided in two. So the first part is called the follicular phase, and during the follicular phase, what happens is a few of the follicles in the ovary mature. Right? And then what happens in day 14, just midway through, is one of the mature follicles actually becomes the dominant follicle, and that mature follicle ruptures, releasing the oocyte. All right? And what happens is there's a short window where the oocyte, if fertilized, can actually be implanted during the secretory phase. So during the luteal phase. And so the luteal phase is called that because the follicle that's left behind degenerates and becomes the corpus luteum. All right. The other thing to note is that in the first half of the ovarian cycle, it's the follicles that are secreting the estrogen and progesterones, and in the second half, it's the corpus luteum that's actually secreting that. And also in the second half of the ovarian cycle, what happens is the corpus luteum slowly degenerates until it stops secreting progesterone and estrogen. And then what happens is that drop in progesterone and estrogen is what actually makes the endometrial lining slough off. All right. So as I said, as progesterone and estrogen levels drop, assuming that implantation and fertilization has not occurred, what happens is that causes the blood vessels in the endometrial layer to actually constrict and basically kill off the endometrial layer. And then you have the start of the menstruation period, which is typically considered to be 5 days. And then again, if you look at the ovarian cycle in the endometrium, so day 1 to day 5 is a menstrual period, and then day 5 to about day 14 is what's called the proliferative phase, where there's a new endometrial lining forming. And then days 14 to day 28 is when the endometrial lining just gets thicker and healthier and more vascular in preparation for implantation. In terms of regulation of hormones during the ovarian and uterine cycle, you can see here again 28-day period, ovulation in the middle, menstruation in the first 5 days. Right? So the top half of the top graph basically just shows you the relative concentrations of estrogens and progesterone during this time. And so what you can see here is at the beginning, the first half, the follicular phase, you've got mainly estrogen in the form of estradiol being secreted. And then what happens is right before ovulation, so about day 13 or so, estrogen levels drop. And when estrogen levels drop, you have a huge rapid increase in LH, and this is called the LH surge. And so it's this increase in LH, the LH surge, that causes the mature follicle to actually rupture and cause ovulation. All right, and then after that, you can see that estrogen levels drop off, and then progesterone levels start to rise there. And progesterone is responsible for making sure that the endometrial, the current endometrial lining gets nice and thick and ready for implantation, as well as to develop vascularity in order to support a pregnancy, and to also develop the placenta with the pregnancy. Pituitary hormones that are involved in this whole process are FH and LH. So FH stands for follicle stimulating hormone. So you can see from that what the role of FSH is. And then luteinizing hormone, you can see, is involved in that LH surge. And you can see here that LH is also involved in the second half to actually stimulate the production of progesterone. And then over here, we've got it all put together. So you've got estrogen, secretion of estrogen throughout the menstrual, ovarian, and uterine cycle. And then progesterone is really responsible for the second half of the cycles. Right? And then in terms of LH and FSH, you can see that the surge for LH comes just before ovulation. FSH follows closely behind. All right, so in terms of estrogens, major estrogen produced is called estradiol, and it's produced by the ovaries via the follicles and then the corpus luteum after ovulation occurs. Effects of estrogen on sex characteristics are listed over here, right? So again, it's involved in proliferation of the uterine epithelium, so that's the endometrium, and it's also involved in secretion of mucus from the endocervical glands. You can see over here, estrogen is involved in suppressing bone mineral resorption. So what happens is it decreases osteoclast activity and keeps bone healthy, right? So that's why in menopause, osteoclast activity increases because there's no estrogen break. Right? There's no estrogen to put a brake on the osteoclast activity. It also has shown to have favorable effects on cholesterol, and that's why with menopause, when you have a decrease in estrogen levels, then what happens is then you have an increase in LDLs, a decrease in HDLs, and that can lead to arthrosclerosis and all its attendant effects. And then the third one is blood coagulation. So it increases some clotting factors. It inhibits the antithrombin while promoting fibrinolysis. And so again, the use of estrogen as a hormone replacement therapy or in the use of contraceptives does actually have an increase in the risk of venous thromboembolism occurring. Right, depending on the person. So it might increase the risk of a cardiovascular event. Some of the adverse effects due to excessive amounts, again, promotes growth of pre-existing breast cancer. It has been shown to increase the risk of ovarian cancer as well as endometrial cancer, cardiovascular events, nausea, and it also causes gallbladder disease, jaundice, and headaches. So this one I've actually just put in here because you can see later on the effects of estrogen on women as it pertains to hormone replacement therapy or as it pertains to contraceptive use. This next slide gives you again the same information, but this time on progesterone. So the main progesterone produced is called progestin, and before menopause, it's mainly produced again by the ovary, via the follicles, and then the corpus luteum during each cycle. And then during pregnancy, the placenta produces large amounts not only of progesterones but also of estrogens. Right? Functions of progesterone, because it's released secreted in the second half of the ovarian and uterine cycle, it actually prepares the endometrial lining for implantation of a fertilized egg. So there's an increase in secretions again to actually prepare the endometrium for implantation. And it's also been shown that if you decrease progesterone levels, or you block the effects of progesterone, it can lead to shedding of the top layer of the endometrium, or in some termination practices, progesterone blockers are also given in combination with prostaglandins to actually induce terminations of the pregnancy. All right. Progesterone is also involved in maintaining the uterus, so to keep the uterus healthy during pregnancy by suppressing uterine contractions. Again, this is why if you block the effects of progesterone, it can actually lead to a miscarriage or an abortion, a medical abortion. And it suppresses the maternal immune response so that the maternal immune system does not reject the fetus. All right, so adverse effects of progesterones are listed over here. So if these female sex hormones are given as exogenous hormones, this is what you get. So exogenous estrogens are given as part of a postmenopausal hormone therapy to treat female hypogonadism when there's not enough estrogen and progesterone being secreted by the by that woman's ovaries. It's used to treat also used to treat acne. Right, so estrogens are given either orally as transdermal patches or as transdermal patches, and these are replaced once or twice weekly. Most common adverse effect is nausea, but it's also been shown to increase the risk of cancer of the endometrium, breast, and ovaries, and it's also been shown to increase cardiovascular events depending on that person's genetic makeup through increased levels of clotting factors and through decreasing of the fibrinolysis. Exogenous progesterone, again, given for post-menopausal hormonal therapy and to also control both uterine bleeding and to also promote the development of menstruation, right? So progesterone is also given to stop premature birth, or to actually delay premature birth, to help with infertility if implantation is the issue. But it also causes endometrial carcinoma and hyperplasia, right? Because progesterone has been shown to be teratogenic, you need to avoid high doses in the first 4 months of pregnancy, because that's been shown to increase the risk of birth defect. And also, progesterone has also been associated with spotting on days that are not the menstrual period, or breakthrough bleeding. Now, with hormone replacement therapy after menopause, I've got a couple of graphs that I'm going to go through. So the first graph is basically the amount of gonadotropins, so that's LH and FSH, that's excreted in the urine. Right? So again, what we're going is we're following the red bar, the red line, right? So again, before puberty, it's almost pretty much zero, and then right about puberty, it starts increasing, right? And then during the reproductive years, it also is increasing, and then after menopause, you've got this sharp increase over here, and then it goes down right there. All right? And the reason for the sharp increase at menopause is because at menopause, what happens here is that estrogen levels drop, right? And so you know the hypothalamic pituitary axis, where you have gonadotropin releasing hormone being secreted by the hypothalamus, traveling through the hypophyseal portal system to release FSH and LH, and then that travels by the systemic circulation to the ovaries to cause a release in estrogen and progesterone. right? And so what happens after menopause is that the levels of estrogen go down, and so that forces an increase in GnRH, which then stimulates an increase in FH and LH to try to increase the levels of progesterone and estrogen back to normal. But again, because of menopause, estrogen levels and progesterone levels drop, right? And that then causes this big increase in LH gonadotropin release. All right, and then the second graph down below is the level of estrogen. So again, before puberty, there's hardly anything, and then at menopause, during puberty, you've got this these surges, right, over a 12-month period between ages 12 and 13. And then it kind of stabilizes. So this up and down represents the levels of estrogen as it goes up and down during each ovarian and uterine cycle, right? And you can see that the up and down pattern continues throughout the very, very compressed reproductive years. And then after, at menopause, the levels of estrogen decrease down to really before puberty levels. All right, so that's the long and short. So symptoms of menopause result from a decline in estrogen production by the ovaries. And what they've shown is that the hormone replacement therapy is good for a couple of years, a few years, because after that, then the benefits do not outweigh the risks. Right, so if you look at the adverse effects, you can see the adverse effects are quite serious. So you've got cardiovascular events, including myocardial infarction, stroke, pulmonary embolism, and deep vein thrombosis, right? You've got increased risk of cancers of the endometrium, breast, and ovaries, gallbladder disease, dementia, and urinary incontinence. So these are the big major adverse effects, and the adverse effects increase the longer HRT continues in a person. And so the current recommendation is that you give HRT for at the lowest possible dose for the shortest possible time. And it's basically given for a couple of years, a few years, just to get over the transition post-menopause. Right, during menopause. So it's given to actually relieve vasomotor symptoms, which is a nice way of saying, of talking about hot flushes or hot flashes or night sweats. It's also given to manage urogenital atrophy and to also prevent osteoporosis and the related pathological fractures. But again, if you take it for a long time, you do prevent osteoporosis, but it must be taken long term, and that increases other risk, as we said, that are cardiovascular and cancer related. So we're going to move on and talk about birth control methods. So the first one that I'm going to talk about on the right-hand side is the failure rates of these birth control methods. So you can see here that subdermal implants have virtually a 0% failure rate, so it always works, right? Intrauterine devices have a 0.2 to a 0.8 failure rate, so it works over 99% of the time. Male sterilization, again, works over 99% of the time, 99.85% of the time, pretty good odds. Female tubal ligation works for over 99.5% of the time. Intramuscular contraceptive, Depo-Provera, works 97% of the time. Contraceptives, either as a oral patch or a vaginal ring, works 92% of the time. Condoms and diaphragms work 85% of the time, and periodic abstinence work just 3/4 of the time. Right? So again, you've got a higher failure rate the lower you go, and it's more effective the higher up on the scale you go. All right, so having said that, what really happens is this. People usually choose a birth control method based not really on their effectiveness, sometimes based on their safety, but the number one choice is because of personal preference, right? Maybe it's easier to take a pill once a day. Maybe you want the convenience of a subdermal implant that you don't have to think about, or an IUD or something, right? So again, effectiveness, safety, and personal preference actually informs a woman about the selection of birth control method that she chooses to use. Now, this pie chart on the right basically gives you the percentage used for birth control methods in the US, right? So you can see over here, oral contraceptives, even though they're quite low down, they actually make up about a third of the method of contraception use for women. And then you've got sterilization, right? So 27% female sterilization, which is the tubal ligation, or 9% for male sterilization. So again, sterilization make about just over a third. Male condom makes about a fifth of the contraceptive use. And then if you look at this, right, Depo-Provera, which has a very high success rate, IUD, and other methods, they're not really very commonly used, right? And it might be lack of information or access or something, but they're not very commonly used, even compared to, say, like a male condom or a male contraceptive. Now, one of the things with contraceptives is that the way it works is basically the same, independent of the route of administration, right? Obviously, if a contraceptive is administered vaginally, then it might need a lower dose because the ovaries and the uterus are just right next door, all right? But really, the route of administration, the way that contraceptives work is the same regardless of the route of administration. All right, so what happens over here is you've got the general mechanism of action. And so you can see here I actually separated out into what estrogen does and what progesterone does. All right, so estrogen, because estrogen is given at the same level, right? What happens is because it doesn't drop down, it will not promote an LH surge. And remember, it's the LH surge that triggers ovulation, right? So if you have no LH surge, then you have no follicle rupturing, no oocyte release, and then that nixes the whole idea of pregnancy occurring. Right? Progesterone thickens the cervical mucus in contraceptives, and so it blocks the entry. It forms a physical barrier, stops the sperm from entering into the uterus, and it also changes the endometrium so that it isn't as healthy or isn't as strong as if contraceptives were not taken, and it serves to block implantation in the uterus. Right? And this is because estrogen and progesterone, given singly or together, the levels of estrogen of these hormones in the contraceptives basically stay the same throughout the cycle and doesn't go up and down very much from day to day, right? Compared to what happens normally. Adverse effects of estrogen and progesterone, you can see here you've got venous thromboembolism due to an increase in clotting factors, and this risk of thromboembolic disorders increases with smoking and any past history. Right? Progesterone increases glucose levels and also promotes breakthrough bleeding. Right? Systemic acting contraceptives, There is some evidence, although it's not very clear, to show that it protects against ovarian and endometrial cancer, and it may not have an impact on cervical and breast cancers. Now, so we've got the mechanism of action of combination contraceptives, and you've got the adverse effects over here. That's just given together as a whole. And then you've got progestin-only contraceptives, which are sometimes called the mini pills. And so if it contains only progesterones, then it doesn't increase the risk of thromboembolic disorder, or any of the adverse effects that's really associated with estrogen, right? Safer slightly than combination oral contraceptives, but it's less effective. And as I said, because it's progesterone, is more likely to cause irregular or breakthrough bleeding or spotting. Interactions of oral contraceptives with other drugs. You've got over here, some drugs and herbs reduce the effects of oral contraceptives. And so you've got anti-epileptic drugs. You've got St. John's wort, which is a herb. You've got tetracyclines and ampicillin. And so if someone is on one of these antibiotics or some of these other drugs, you need to actually supplement the contraceptive action with another method, such as the male condom, right? The second point are drugs whose effects are decreased by oral contraceptives. So if someone is on oral contraceptives and is on warfarin, insulin, and oral hypoglycemics, the effects of warfarin, insulin, and oral hypoglycemics might be decreased, right? And then the last one is drugs whose effects are increased by oral contraceptives. Theophylline, which is used to manage asthma, tricyclic antidepressants, as well as diazepam, which is a benzo. Some alternate birth control method apart from the oral contraceptives are listed over here. So you've got a vaginal ring that contains combination contraceptives, and so what happens is you've got a ring that you insert into the vagina once a week for 3 weeks, and then you get a 1 week break so that menstruation happens, and then you repeat the cycle, right? So you've got the effectiveness of the vaginal ring. And then the second one is a patch. So again, replace every week for 3 weeks, 1 week break to allow the menstruation to occur, and this may cause more thromboembolic events. It's less effective if a person is over, it's 200 pounds or over. And then the last one are long-acting contraceptives, either given as subdermal implants or as depot, either intramuscularly or subcutaneously. Right? So again, very effective because you just inject it or implant it, and then you can forget about it. But again, because it also contains progestin, then it has it leads to irregular bleeding. The next lot of drugs I'm going to talk about are drugs that affect uterine function. So you've got over here drugs that relax the uterus to suppress preterm labor, drugs that stimulate the uterus, right, to augment or induce labor, to control postpartum bleeding, or to induce abortion. And then we're not going to talk about the third class, but the third class of drugs are used to actually decrease menorrhagia or heavy menstrual bleeding. So uterine relaxants are also called tocolytics, and tocolytics are given to actually relax the uterine smooth muscle during preterm labor, and its function is to actually delay labor for up to about 72 hours so that the lungs have time to develop. So sometimes it's given in combination with glucocorticoids to accelerate lung development, or if there's an infection that needs to be treated, it actually buys time to actually treat that infection. right? So control of myometrial contractions is regulated by beta receptors, oxytocin and prostaglandin. And so you see here the uterine relaxants, some of the other ones are listed over here, right? The drug of choice in terms of tocolytics is magnesium sulfate. And magnesium sulfate basically inhibits acetylcholine release from the neuromuscular junction of the uterine smooth muscle, so it inhibits contraction. But it also crosses the placental barrier and enters into the fetal circulation, so it can cause profound weakness of the fetus, right? And it can also cause respiratory distress, which is what we want to avoid in a premature preterm baby. The other thing too is because it does cross the placental barrier, and because the kidneys in the newborn are immature, the magnesium sulfate may actually hang around in the system for 3 or 4 days, and so it's really important just to watch the infant for those 3 or 4 days, particularly for adverse effects related to weakness of the skeletal muscles, right? Other drugs that are used as uterine relaxants are beta-2 adrenergic receptors, which suppress but doesn't prevent preterm labor. So if preterm labor has already started, you can actually give beta-2 adrenergic agonist. You can also give calcium channel blockers to actually stop the contraction, or to inhibit the contraction. You can give non-steroidals, anti-inflammatory drugs, because they basically inhibit prostaglandin production, and prostaglandin promotes contraction. And because oxytocin has been known to stimulate uterine contractions, if you give antagonists to the oxytocin receptor, it slows it down and relaxes the uterine smooth muscle. Right, so these are tocolytics. This slide basically talks about drugs used to promote cervical ripening. So basically the drug that's used, the drug of choice, is a synthetic prostaglandin called dinoprostone, right? And it basically is similar in structure to a prostaglandin E2 that's produced endogenously. And so that's when prostaglandin PGE2 is produced endogenously. It basically promotes cervical ripening and stimulates uterine contraction. And so you've got over here when it's used. And again, because it stimulates uterine contraction, one of the adverse effects is extreme contraction of the uterus, right? Uterine tachysystole, which means in extreme, remember systole means contraction, tachy is fast, so uterine tachysystole is extremely quick and hard contraction of the uterus, right? And again, if it gets into the systemic circulation, it can cause these adverse effects. So it can be given either as a gel or a pouch vaginal insert. Next one that I'm going to talk about are uterine stimulants. So you've got oxytocin, ergo-alkaloids, and carboprost. And so oxytocin is used to augment labor, postpartum use, to actually contract the uterus and to actually deliver the afterbirth, and also used as part of the abortion process, right? So what happens is it increases the force, frequency, and duration of contractions, and so the contractions speed up and are harder, are stronger than what they would normally be, and it can actually cause uterine rupture, right? Because it gets so strong and so frequent. Oxytocin is very similar in structure to ADH, and so it can cause water retention or intoxication the same way that ADH can. Alkaloids are used to control postpartum bleeding to augment but not induce labor. And so it causes, again, it increases the intensity and the duration of uterine contraction, but it also causes vasoconstriction. And so this vasoconstriction is responsible for the hypotension as an adverse effect. And then the last drug here is used to mainly control postpartum bleeding or to induce abortion. And again, vasoconstriction over here is also good to control postpartum bleeding. Right? So basically, carboprost increases uterine contractions to induce abortion, and because it causes vasodilation, it can control postpartum bleeding. And then just to end on a good note, I've got this picture that I went to the dollar store, must be a few years ago, where you've got, you can buy condoms for $3, and then if that fails, you can buy pregnancy tests for $1.25, right? And then just on a last note, if you're thinking about breastfeeding and drinking, there's a test milk screen that has strips to test the alcohol level of your breast milk. And on that note, I'm going to end.